So today I'd like to talk about a couple of projects I have been working on in the past 4 years, which primarily centered on the use of electronic medical records, how clinicians adapt and appropriate the systems to better fit with their working habits. Because most of the people here are actually students, I'd like to start with a little bit of background of biomedical informatics. This is the picture of this year's chairman of the American Medical Informatics Association conference. And one of the things Bill Hirsch actually mentioned in the conference is that we tend to think about the medicine as the health sciences or life science. But in many ways, it's actually information science. And when we are producing more and more patient data, it's becoming more towards the information science. And why we think this is information science? Many of you are here. I heard many of you are actually physicians. You're taking the MPH program. We all know that information is the base for us to diagnose and treat the patient. The information is the base for clinicians to communicate with each other, to provide continuity of care when the chronic care patient visit different hospitals, different medical doctors. And it's also the basis for hospital administrators to provide statistical report on the infectious rate, all kinds of issues in the hospitals, as well as clinical and public health researchers. And a lot of times, when we think about this information, where is this information? A lot of times, they're actually in patient medical records. That is a central information repository for clinicians and patients and researchers to use. So when we think about medicine as information science, we wanted to center the information science on the use of medical records. And what does a medical record look like? This is a traditional view of the medical record storage in hospitals. As you can see here, there's a lot of patient chart on the storage, and a lot of study has looked into these problems. Not only is it really difficult, it takes a long time to retrieve the chart from the medical record storage. Their study even showed when there's a medical chart on doctor's office, in doctor's office, on their desk, at the point of care, more than half of the doctors could not find patient information in the chart because it's really difficult for them to find relevant information when there's a lot of different papers in the chart. So when we think about these issues, it's become more difficult for researchers to access to, for example, 1,000 patient record to do some chart review type of clinical studies. So the traditional paper medical record has a lot of disadvantages. Instead, just the recent 10, 15 years, we're actually moving into a digital age in the health field. So more and more hospitals are starting to use this, what we call electronic medical record. This is just some pictures I found online. As you can see here, it's really changed the people's view towards health sciences, medical practices. It's really clean. The doctors can hold something while they're talking to patients. They can document on their little machines. So what is the EMR? By definition, EMR is organizational-wide information infrastructure that creates, gathers, manages, and stores digital version of patient paper chart. So it's basically turning into the paper chart into something put in doctors' computers, in a computer system that everyone can access to. So there's a lot of benefit of using the EMRs. First of all, there's a lot of benefits to its primary users. For example, the doctor, nurses, specialists, they now can access patient information in real time at any places they wanted to. The charts are well organized. They can search, like you search in the Google webpage, and they can read the chart really clearly. It's not handwriting, it's typed out. It also benefits a lot of secondary users, such as researchers, administrators, and a lot of you, like public health practitioners. People use that information to access what's going on in our field. they do epidemiology type of studies. So there's a lot of benefits about regarding after you have the electronic medical record. I just remembered I went to visit CDC before, and the CDC largely are using this electronic medical record. They connect with many hospitals. They collect data in real time, so they could monitor whether there's epidemic information going on. So there's a lot of benefits we hope we can realize in the future. However, people have been using this technology for a while, and it's really expensive. It costs a couple of, I heard last time when I talked to the CIO in UCI Medical Center, it cost $700 million to implement such a systems in UCI. It's really expensive, and a lot of times previous study found out there's conflict result after people been using it. As one of these articles showed, people hoped that using electronic medical record could reduce the cost and reduce medical errors. However, many times it's not like that. Many studies reported different findings. Another study also showed after people been using the electronic medical record, the cost went up, and also nurses spend more time on documenting or using the EMR per patient. So that's a very interesting and controversial result. When we think about a lot of promise about the technology are actually centered on people can benefit from these systems. People like to use it. There are a lot of survey studies that surveyed clinicians, doctors, nurses, asking them whether you would like to use the system or what the problems with the current EMR, and what you think about what are the barriers for you to use the EMR. And there's a list of issues. For example, the doctors think that they're losing eye contact with their patient when they're using the technology, or they're falling behind the schedule because it takes too much time for them to use EMR systems. Computers are being too slow, and they're unable to type quickly enough. So there's a lot of issues about using the electronic medical record systems, and as a result, many doctors refuse to use the systems, and many times we consider this as adoption failures. They refuse to use, there's a couple of cases, doctors refuse to use the electronic systems, and they prefer to use their previous paper chart. They continue to use the paper chart instead of adopting the new systems. As this article shows, people did compared adoption rate between 2001 to 2004 and 2001 to 2007, and they found adoption rates are actually, there's actually some adoption problems in the second phase of this in the States. So there's some articles showing that. I just quote some really nice lines about the system in use. So this is actually an article published in the Journal of Biomedical Informatics. And this article shows, while using the technology really makes the information available to people, so you can really access to it. You can really access to information at the real time. However, the availability of the information to people are not very satisfactory. So people are not satisfied with what's being put in the electronic medical record. When I read this line, it really shows to me that there's a better ways to represent and to push information to people in the systems. And it's really, there's a better way for people to design the system better, to feed the information to clinicians. Also, this is the articles published in 1996, which is a computer science articles. And this article also talked about the same issues. They mentioned about after people been using electronic medical record, or in this article called electronic patient record, the medical charts are organized better. However, how doctors actually document through the chart was not considered in the system design, which lead to a lot of adoptions issues, and people are not satisfied with the computer system design. So with that, we talked a lot about adoption. People are not happy with the system. They're not satisfied with it. They pointed out to a lot of issues. I'd like to turn the attention into the terms called adaptation and appropriations. So designing system, the electronic medical record systems, obviously is very difficult. When we think about the systems being used in such a complex environment, it's really difficult to design a system right at the beginning. Instead of considering about adopting system right away, many times in the computer science field, we found out that users may adapt and try to modify the system use for a prolonged period of times to achieve their goals, which I will talk a little bit more about what they mean. And for me, I'm really interested in what can we learn from users' behaviors, how they adapt to the systems. So first of all, what is adaptation? People found out it often takes time for users to learn and adapt to the new technologies. When we think about adaptation, it's a process for users to modify new technology, a relevant aspect of the technology or the environment to better facilitate their work, which including their skills and procedures. So when we think about adaptation, there are two ways of adapting it. First of all, you can change the technologies. And secondly, you can change the behaviors. For example, I try to use some other ways to use this computer system to make me go through this chart quicker. And you may ask me these questions. How would clinicians, if we think about clinical context, how would clinicians change the technological design? I will give you some examples and to let you know how they actually adapt to these technologies. And the next term, very similar terms I'd like to point out, is called appropriations. In my home field, people talk about appropriation as many times creative use of technologies. For example, it's beyond its original design. As the pictures I showed here, people design the camera on your cell phones for you to take a picture. But a lot of people use the cameras to take notes as a note-taking tool. This also another picture shows people may print in this very creative ways using their iPad. So users may engage in creative use, which designers never thought about. And it's very interesting for us to see what kind of creative use they actually came up with and why they're doing this. When we think about things in healthcare, people don't always use adaptation or appropriation in healthcare context. Instead, many people use workaround. When we think about healthcare, medical informatics people, they always talk about workflow. You do things, follows a flow of actions. And when there's new technologies, many times people found out people don't really follow the flow or designed by the technologies. People work around it. They create new ways of using technologies. And there's a lot of papers talked about workaround, or sometimes they call this unintended consequences of technology use. So those unintended consequences sometimes are creating new processes, and sometimes are bypassing new technologies. Either I create new ways of using it, or I'm not using it, or doing something else. So there are some previous reported examples. For example, people continue to use paper chart. When there's a computer system, I don't use it. Or I create some kind of paper notes, which designers never thought about. They're thinking they were designing a paperless environment. Instead, people are using a lot of paper notes. And there's a modified workflow. And there's a lot of creative use of technology, which I'm about to talk about this. So what has not been studied in previous literatures? In medical informatics field, people reported a lot of workaround. They categorized the workaround into different types. However, there's not a lot of studies talked about why people are actually engaging in that kind of creative use or adaptation behaviors, and what motivates users to do that. Obviously, they need to create something. They need to think through something and why they're doing it, and what can we learn, and how can this benefit technology design. So that's the research gap I saw from previous studies, and that's the contribution I hope my research could contribute to in the future. So some of the study, just a summary of the study I've been doing. I already talked about research goals. I'm interested in what kind of adaptation or appropriation behaviors are there in the medical field, and why people are doing it, and how can we learn from those activities. With that goal, I did a couple projects in a different medical environment. For the talk I'm going to talk today, the data are actually from 2 emergency departments and 2 outpatient clinics. Those 2 emergency departments actually in different healthcare organizations. One is a teaching hospital, the other is a regular trauma center. And also for the outpatient clinic, they're in the different socioeconomic situations, which lead to very interesting and different results. I use qualitative methodologies because previous studies suggested if you're interested in adaptation behaviors, you really need to use the bottom-up methodology. You really need to be there to observe what's going on instead of asking people directly. My studies are still ongoing. Some of my students are still collecting data right now, but so far we have about 1,000 hours observation from different projects and 50 user interviews so far about clinicians' part. We did a lot of data analysis. We used graded theories to code the data, which whatever emerged from our field notes, we saw and we saw the behaviors, we saw the patterns, and we code that. And we also use a lot of diagramming method, as you can see from the background, in order to see the process, how people actually work around things. What is the process for people to do things? We use a lot of diagramming methods to see the big picture of it. So I'm not going to talk about all the findings in my studies, but today hopefully I wanted to work through 3 cases and show you how users adapt and appropriate the EMR systems. So when I say users, most of them are doctors and nurses in my studies. So those are the pictures I took in my field studies. As you can see here, computer systems are everywhere. Those are from different hospital settings. The doctors always sit in front of their computers. There's always different computers. I mean, almost every 3-4 steps you can bump into a computer. However, there's a lot of workaround in these pictures. Not sure whether you can read it, but I'm going to talk about this one by one. So the first one, we talk about personal notes. This is probably the most popular workaround has been reported in previous literature. A lot of people talked about what's going on with our field. There's a paper resistance. Why we have such a nicely designed technology, but there's still papers. There's still papers everywhere. If you can see the previous picture, almost every single one, you can see papers. So I'm going to report the first one. This is actually from my students' work. So we studied electronic medical record deployment, which by deployment, we studied the paper record use first, and we studied the rollout of the new technology, and we continued to study, observed how people actually use it over a period of time, which gave us a really good opportunity to say, well, why those kind of new workaround or adaptation behaviors actually emerged after the system rollout. So after 3 weeks, 2 to 3 weeks after the new system rollout, we found out a lot of doctors are starting to use this paper chart, small paper notes. As you can see here, the doctors holding a list of the paper notes, like the card you're holding, and they put on their pocket. So we actually asked doctors why you're using it. You're not having it before. They're not using this kind of paper notes before. So as you can see here, a lot of doctors told us, well, when I'm talking to the patient in the bedside, it's really hard for me to record information. I may not remember people's name. I don't know what's going on with this patient. They have complaints. So I need something for me to remember who is the nurse in charge of this patient, their name, why they're here every day. I don't have this memory aid for me. So they need to put things on this little piece of paper and hold them. So because there's a problem with the electronic medical record use, when doctors first created this adaptation behaviors, there was no bedside computers in the department. So it's really hard for them to use or to retrieve patient information at bedside. But similarly, other studies we did also found even there's the computers, it's really hard for doctors to use the computers while doing their diagnostic or interviews with patients. So they create this small personal note. As you can see here, the doctor actually mentioned, well, I only need those basic information about my patient so I can remember it. But there's no way for me to see it. There's no such a system available. Therefore, I'm creating something on myself that I'm using it every day that can help me. So in this case, as we can see here, the paper note did not replace the documentation in the electronic medical record. However, they extend the documentation systems in the computer into a paper and a computer combination of systems for doctor to use, which is easier to fit into their workflow. So later, we also analyzed what actually put on this small note. Right, the doctor told us they actually put patient names and sometimes their chief complaints there. We did analysis of emergency department as well as the collaborators in the labor and delivery department, which is the inpatient unit. We found out those personal notes contains very similar information. We summarize this as memory work for things the doctors should remember, but there's nowhere to put them. And the second type called abstraction work. The abstraction work is actually very interesting. A lot of doctors, nurses complain, well, the electronic medical record has a lot of information, but it's really hard for them to extract or see the really useful information for them. In that case, people just abstract a few key information or keywords, and they put on their small paper notes. So they always remember what's going on with their patient. And the third one, called future work. Sometimes the doctor has some hypothesis about this patient, which is not confirmed. They cannot put that in the electronic medical record, so they put on their small paper notes to remind them, I could go back with this hypothesis and say which one of this. After I got the lab result, I can take a look at them afterwards. So this is very interesting for us to think about. A lot of previous studies said, well, when people use this paper note, you give them an iPad, you give them an iPhone. They could read information on the iPhone. Those would solve all the issues. But instead, our study actually suggested it's not the case. Well, there's a lot of information need to be abstracted or need to be displayed in a way that facilitates their work practices. It's not as simple as rolling out the EMR into an iPad would solve all the issues. So that leads to a lot of redesign thinking that we can use for future design. So this is just another example in another emergency department. As you can see, there's the electronic medical record, but doctors always have this paper chart looking documentations on their desk, which they use this paper chart to hold the information about the patient. When they talk to the patient, they have to write a really long progress notes about what's going on with this patient, the reasoning behind the diagnosis. But many times they cannot do it because they need the lab results. They need a lot of backup supporting information before they can write that kind of note. Because of that, doctors use this paper notes, paper chart to hold this information until hours later when they have time, when they have all the sufficient information to write their progress notes. As you can see the doctor on the top, he's actually very interesting. He has paper chart with every single patient he's handled at this moment. So he has those charts organized in different piles. One is completed, the other is in progress, the other is waiting for the lab results. So a lot of interesting things here. So all those paper notes, paper charts, after doctors putting them back into the EMR or after the patient is discharged, they would just throw it away in a central place and the department would recycle them afterwards. because there's patient private information on that. So that's the first one. As you can see, the doctor and nurses created some kind of new paper-based documentation too. The second case is also very interesting, what we saw in an emergency department. This is actually a case I heard from many doctors in different hospitals. After people been using electronic medical record systems, a lot of times they found it's really difficult for them to print things out from the systems. And we found, just in our field site, what happened is doctors could use multiple systems, and they're always on mobile. When they're seeing one patient, after they talk to one patient, they wanted to use a computer system just nearby. When the doctor need to print what we call transmitters, when I put in a lab, when I enter the lab orders, like I need to do a blood test for a patient, they need to print something, a small label called transmitters, to go with the blood samples, so the lab department would know what's going on. But after people been using the electronic medical record systems, it's really difficult for them to do that, because it's always print from the systems where the doctors first logged in. So when they're trying to print from the patient bedside, the printout would go to the computer they first logged in. So there's multiple printers in the emergency department. It's really hard for doctors to remember after I print it out, where do I find these transmitters? They couldn't find it afterwards, and they become very frustrated about that. As you can see here, the quotation here said, well, it's very annoying because you have to give that transmitter to the nurse, and sometimes we don't know what printer it's going to. It's really hard for them to remember that when people are actually taking care of that many patients, and they always are mobile in different places in the emergency department. As a way to solve these issues, obviously, they're not able to change the EMR where this system, where the things should print to. Instead, they change the printers. So there's only one central printers in the emergency department afterwards. So wherever you print, it always goes to this central printer. So there won't be issues like, I don't know what's going on. I don't know which unit I should pick up my transmitters. So, however, it creates a little bit more problems because it's a large department, and it takes a lot of time for doctors to go back and forth to pick up these transmitters. So then they switch this workload to nurses, and they ask nurses to pick up the transmitters because nurses are actually nearby the patient. They have more free time to do that. So there's, through a reconfiguring of the socio-technical environment, doctors were able to solve their problems of not knowing where to pick up their transmitters. And they solved this problem eventually. I wouldn't say every single one super happy with this solution, but at least I would imagine some nurses probably were not happy for having this new job responsibilities. But at least they're able to send the lab orders quickly without any problems. So as we can see here, doctors are not able to change their EMRs, but they're changing their physical environment to accommodate some kind of problems in the technology design. So the last case, this is actually a study conducted by myself. It's in the outpatient clinic. As we can see here, a lot of previous studies in medical informatics field are suggesting when you're using a computers in the exam room, when you have a patient in front of you, it takes a lot of time and takes a lot of attention from your patient to the computers. Now the computer actually takes away a lot of time and attention. And I actually draw these diagrams. As you can see here, when you have a computers, it's definitely force your patient to stay relatively away from you. The doctors cannot stay very close with their patient as they're holding a physical charge. And as you can see here, a lot of previous studies suggesting there's less eye contact. And those studies, they're suggesting you're either facing your patient or you're facing your computers. There's no way, there's just one mode of communication. in the entire medical visit. A lot of studies suggested, well, the doctor has to force to facing back to their patient when they're trying to use their computers, like this. So it's actually very interesting for us to look at different behaviors, how doctor appropriates the technology in the exam room. So I studied in the outpatient clinic. As I mentioned, the computer system in this clinic were not placed in a desktop. They're actually on a mobile cart, which is very common in medical settings. They call it computer on wheels. And the mobile cart were always plugged in because you have to plug in, you have to charge the computers. However, it allows the doctors to twist the computers into different angles during the medical consultation, which lead to very interesting phenomena. So when I sit in the exam room watching how doctors use computers, I always saw almost every single one twist their computers during the same medical consultation. They're not using the computer in the same way during these 20 minutes. Instead, they use it in many different ways. So we categorize them into 3 main categories. First of all, we call this communication intensive stage, which often happens at the beginning of the medical consultation, where doctors have to ask a lot of questions to their patient. What's your syndromes, what's your feelings, and why you're here today. In that stage, the computers are always facing doctors. They sometimes also type in things in the computers. This is very interesting because obviously the computer still takes away some attention from the patient, but when the patient and the doctor could see each other face to face during this conversation intensive stage, doctors can look at the computer, can look at the patient, switch their attention away from computer, look at the patient eye to eye directly. And the second stage, we call this lecturing stage. A lot of times during the same medical consultation, the doctor would flip the computer away to their patient and looking at the lab results or some kind of information on the screen. As this picture shows, they pointed to some abnormal lab results and asked the patient, say, this is a normal lab result in your blood test this time, and you should pay attention to it. So the doctors and patient are engaging in this collaborative learning or viewing stage. This is the second one. And the third one, when doctors are putting in orders, they put the computer in a relatively neutral stage. They're not trying to hold the computer screen or share it. The patient may want to take a look if they wanted to, but sometimes they just say they're not looking at it. So what does this mean? I'm going to talk a little bit more about this. So previous study always shows, well, the doctors use the computer in the same mode throughout the medical consultation. And sometimes it's really hard for doctors to make eye contact or for patient to engage in the information on the computer screen. We saw the doctor moving things back and forth. They didn't move it purposely. They have a lot of goals behind it. For example, the screens are typically block human eye contact at some way. So when the doctors put the computers in between patient and them during the conversation intensive stage, they could make eye contact when they had a chance, because they could look up and they could look at the patient. And also, using the computer is a way for doctor to creatively use the system to remind them what's going on in the patient chart. Sometimes when the patient goes on and on something off the topic, talk about their personal issues, we saw a lot of cases in doctors use the computer system to remind them or to bring up new issues that the patient could move the conversation back on track. So it's actually very interesting. Also, negotiating the screen sharing. Many of the previous studies actually said it's always a good thing for your patient to see what's going on your screen, but it's not always the case. In our own studies, we found out a lot of times when patient and doctors are talking about what's going on, their syndromes, doctors are typing something. A lot of those are very subjective information or hypothesis information. For example, I suspect this patient might have some disease. I'm not sure yet. In such cases, it's not suitable for patient to look at the screen. So the doctors are using this negotiating mechanism to hide those highly sensitive information from being seen. And also, in some cases, when it's factual information about the lab results, about the medications, they could flip the computer screen away to the patient side and ask them to engage in meaningful conversation and even lecturing them. So that's a very interesting and creative, meaningful way of using computer in the exam room. And that has not been reported in the previous study. So that's the third case I wanted to show you. So what these cases told us, first of all, it's really hard to avoid the influence of the electronic medical record systems. It's almost impact every single activities in the medical practices. It influences the individual level, how individual doctors conduct their work. It also influences how people collaborate with each other. It also heavily affects how doctors and patients communicate in the medical settings. So it's not something we can avoid. We definitely need to think about the way to better design them. And then the usefulness of the electronic medical record. When people are talking about adoption, whether people are satisfied with it, whether people are like to use it, it's a very localized behaviors. It's highly affected by individual work habits, individual workflow, and collaborative behaviors in the department, as well as something like physical environment, departmental and local organizational policies about using technologies. So a lot of issues creating those socio-technical environments that all affect the technology use. It's not only a computer system alone. There's many other issues all involved into this case. The next one, what are these adaptation and appropriation cases led to? It led to the new ways of interacting with computer systems in the exam room. As I mentioned, doctors negotiate the computer systems into different ways, different angles, for different type of activities. And then it led to new artifacts that invented by clinicians to leverage the weaknesses of the computerized documentations. As I mentioned before, people are not able to change the EMR. Therefore, they created some new artifacts to help facilitate their work. And we actually learned a lot of what has been documented in this chart and why they're doing it, and which could help us to better support or design computer systems to fix those issues in the future. And this also leads to new physical environment or reconfigured physical environment to better facilitate or fit with the technology being designed. Sometimes it's really hard to redesign the technology. There's other issues in the environment, in the physical environment, which people can better redesign their physical environment to facilitate or support technology use. Actually, the two emergency departments I studied, one of which has doctors working in a separate closed charging room, and the other, the doctors are actually working in an open nursing station. As many of you can see, it's a very open space. It's actually changed the way how they use the electronic medical record systems. One emergency department, when there's a closed environment, only doctors can enter into that room. Doctors seldom log off the systems, but when there's an open space, patient, nurses all passing by, doctors always log off the systems. So that's creating the different ways of using technologies. So physical environments are also very important. And there's also new work process, new work roles and policies. I didn't put it in these slides, but we actually saw there's new roles being developed by after people been using this electronic medical records. There are certain steps, for example, the triaging steps takes a lot of time. Therefore, the department are actually creating a triage facilitator who can step up this process after people been using this technology. And they're also creating new policies. For example, the personal notes I showed with you guys, there's a lot of private information on those notes. So the department will collect all these personal notes and shred or recycle them in a centralized way to make sure they will protect people's privacy after this workaround has been developed. So there's a lot of adaptation and appropriation in the department, creating a lot of new ways of using technologies. And what it means, I'll wrap up really quick. Adaptation and appropriation can be viewed as an end-user design process. We can see clinicians are actually actively engaged in those designing a better socio-technical environment process. They actively engage, motivated to do this kind of effort, these activities, because it could make them work better, smoother, and quicker after they engage into this design process. So what we can learn from there, those activities can help us better understand why such things happens and how can we better redesign the EMR in the future to represent or fulfill their needs. And then it led to a process for reconstructing the work routines in the new socio-technical systems. Those workarounds may never go away. So people are using personal notes for years, they're still using it. It's become part of their documentation systems, and it's really useful, and it's become part of their work routines. A lot of medical informatics literatures are suggesting unintended consequences of workaround. It's not a good thing because there's something we didn't anticipate. There's a paper notes use, continued paper notes use in the medical environment. However, we actually think it can be interpreted in the beneficial activities if you understand the behavior behind those workarounds, and there's a way for people to better design the social technical environment in the future to facilitate the work practices that doctors and nurses are really needed. So I wanted to move back to adoption and system design a little bit more. Like we said earlier, there's a lot of adoption barriers. However, we can think about adoption barriers. A lot of adoption barriers can be leveraged through a combination of social technical solutions. Maybe there's a new policy, maybe there's a new workaround, or maybe there's a new technical design could better help people overcome those barriers to increase the adoption rate in the future. And we also think there's new ways of thinking about design in the medical environment. For example, clinicians can serve as invisible designers. They're not designing the technical systems, they're not designing the electronic medical record system, but they're designing the better ways to interacting with the computer systems. They're designing new tools, new artifacts, or even new policies to better use the technologies. And in such cases, those lessons learned could help other medical facilities to better use the electronic medical record, or even help the vendor system to better design their system. For example, we could imagine maybe they can also provide this abstract view when ER doctors are using their computer systems, mobile devices. There's an abstraction view, so they don't have to write the personal notes. And there's always need to be a localized adaptation process is needed to ensure the user satisfaction and the successful rate of the technology use, because every single department are so different, and people's work practice and the local policies are very different. So always has to have such kind of period to ensure people are happy and the use of technology can be emerged with the local context. So that's what we learned from a couple of our field studies, suggesting that when doctors or nurses are engaging in those adaptation, appropriation activities, it could lead to better design and better system use in the future. So I'd like to finish here, and if you have any questions, I'd like to answer them.
We have time for a few questions. Excellent presentation. Thank you so much. a question I'd like to have you comment on. We know that physicians have been reluctant embracers of this technology. Those who have found out they're now documenting better, have better medical records, have the patient experience documented, and now find the conclusion of that they're being investigated for fraud. And the reason they're being investigated for fraud is the documentation is so much better they can justify a higher charge, a higher coding of the medical record for the services they do render. Place that in context. How would you view the future unfolding to address issues like that?
I actually have some other studies that will look at those issues, but I haven't included that in this talk. There do have a lot of previous studies, including my own. I have working papers on this topic, which we found a lot of doctors are, even some of the cases reported here, they're reluctant to put some information in their medical record. As you mentioned, a lot of times those things are monitored by lawyers, by other peoples, and they're trying to find errors, other issues in the medical chart. So there's, I've been thinking about this for a long time. I wouldn't say I have a really good answers for that, but one of the issues I saw is the way how doctors practice and the way how medical record systems are constructed at this stage, actually in quite different ways. When you're practicing, there's a lot of work in progress information. There's a lot of information will need to be modified afterwards. There's a lot of information people documented at the beginning. When you put in the really clear, structured way, it doesn't make much sense until you got lab result, other things. I mean, it's a hypothetical driven field, as I practiced medicine before. But the electronic medical records, there are actually a lot of governmental policies that whatever you put in the EMR, you should not modify it, because that's, as long as we can see it in the systems, we can put it in the court for legal purpose. So there's a huge gap in this stage. So what I was thinking is there should be a cushion time, or there should be a working system for doctor to use as of now. And then when things are ready, I push that into archival stage for legal or other billing purpose. So there's a gray areas that should be supported in the practice stage. I'm working on the paper like that, so I'd love to get some of your feedback after I'm done with that.